So my topic today is going to be on whether vancomycin and Zosyn has increased nephrotoxicity as just compared to vancomycin alone. So I'm going to just kind of bring you to a common scenario that I encounter on a daily basis, maybe admitting a difficult patient with a complex medical history, maybe with an infection of unknown etiology. And I'll think, what antibiotic should I use for this unclear infection in this patient with this complex infectious history? I'll go over all the data, I'll confer with my seniors, and sometimes I'll go down the path where I'll call the experts like Dr. Jose or Dr. Fitzgibbons or our new ID fellows, Dr. Hahn and Dr. Espinoza. And with them, we'll review the case, we'll go over decades worth of patients' medical history and microhistory. I'll get an expert opinion to start ribavacycline, metronidazole, and ceftaroline, so probably working with Dr. Jose here. But instead, I'll start Vancomycin. And I'll say this actually has never really happened before, but it's plausible enough where some memes have been created about Vancomycin. So patient sneezes, Vancomycin. We have a 45-year-old, Vancomycin. There are antibiotics besides Vancomycin. So yes, there are. But I'll say on the kind of flip side, how many times have you guys been thinking about antibiotic regimens for a patient and thought, Vancomycin would be great, got the MRSA coverage, the Pseudomonal coverage, but their creatinine is elevated, maybe I should hold back on that. So we'll kind of delve into the thought process there. So a little bit of history. So in 1952, a missionary in Borneo sent a sample of dirt back to his friend, an organic chemist at Eli Lilly. Really fun package to get. An organism isolated from this sample produced a substance deemed compound 05865, and this was active against most gram-positive organisms, including penicillin-resistant staphylococci. Subsequent animal experiments suggested that this might be safe and effective in humans. Different kind of processes to make the drug purified. It created vancomycin from the word vanquished, which I thought was pretty cool. So vancomycin, the vanquisher, was born around 1958, really didn't become popular until the 80s once MRSA kind of reared its head and pseudomembranous colitis became a big thing. So vancomycin-associated nephrotoxicity, there's a lot in the literature about this. And I'll say that kind of from my very limited look into it, it seems that we can, that vancomycin is nephrotoxic in a dose-dependent manner, whether we're using troughs like we used to in the past, or now kind of the more complex area under the curve. It seems that the higher the level of vancomycin a patient has, the increased nephrotoxicity. This is just kind of a little pictorial of some meta-analyses and a retrospective study kind of just showing that, as far as how did these studies assess AKI, that's something to think about and something we'll address as we go on into this presentation. So what is the mechanism of action of vancomycin-associated nephrotoxicity? From my very limited research, it seems to be that vancomycin produces reactive oxygen species, which will affect the proximal tubular cells in some way. Recent studies showing that vanc-induced apoptosis in porcine proximal tubular cells by peroxidizing cardiolipin in the mitochondrial lipid membranes. Here's a different study that showed that N-acetylcysteine kind of ameliorates this apoptosis that vancomycin induces by reducing reactive oxygen species, but kind of here showing that vancomycin producing reactive oxygen species going down this kind of pathway with these capsaces and producing apoptosis. Let's talk a little bit about Zosyn. So this combination of piperacillin and tazobactam, pip-tazo, became available in 1993. Piperacillin is a broad-spectrum penicillin that is bactericidal against many gram-positive and gram-negative aerobes and anaerobes. Tazobactam is a beta-lactamase inhibitor that shows good inhibitory activity against these beta-lactamases. And so we know that tazobactam reduces the hydrolysis of piperacillin, so leading to increased plasma concentrations of piperacillin. But piperacillin might also reduce the renal excretion of tazobactam, kind of leading to this loop where, I'll just kind of show you in this next slide. In the bottom left, you'll see that, let me just quickly talk about organic anion transporters. So these are transporters, drug transporters that are located in the basolateral membrane of the proximal tubule cells, and they're very important for renal excretion of drugs. It has been shown that piperacillin inhibits the main ones that are expressed in the kidney, so OAT1 and OAT3. So, just kind of starting at the tazobactam on this slide, affecting the beta-lactamases, increased plasma piperacillin inhibiting OAT1 and OAT3, which tazobactam is a substrate for OAT3, leading to increased tazobactam in the plasma, kind of perpetuating this loop. And I will say that it has been proven that secretion of creatinine is very dependent on these OAT1 and OAT3 transporters. And that's important because, so a little kind of clutter here, but if we look at the image on the left, so TZP being pip-tazo or Zosyn, so inhibiting potentially OAT1 and OAT3 and leading to decreased creatinine in the tubular epithelium and then secreted in the urine, so increased serum creatinine caused by Zosyn. We already know that TMP, trimethoprim, and probenecid have these pseudo-nephrotoxic effects where TMP, for example, inhibits the organic cation transporters and also these other transporters, leading to an increase in creatinine, but this kind of pseudo-nephrotoxicity. And, vancomycin, this topic isn't on vancomycin alone, but affecting, through this mechanism potentially of reactive oxygen species, these proximal tubular cells, and potentially also affecting OAT1 and OAT3 by themselves. And just kind of like a little refresher on kidney physiology. So creatinine would be kind of freely filtered. Most of it's filtered, but also 10 to 20% of it is secreted from the capillary back into the renal tubule. And pretty sure that is actually increased for patients that have chronic kidney disease or renal insufficiency. So vancomycin and Zosyn, so we know this combination is, really leaned on heavily and for good reason, kind of having the MRSA and Pseudomonal coverage. So heavy on memes in this presentation. But just speaking a little bit about the nephrotoxic studies. So this was just kind of an illustration that GFR was slower to increase in patients that were treated with pip-tazo, them being kind of at the bottom, versus those treated with cefuroxime or meropenem. Here is kind of a compilation of different studies showing how AKIs increase with vanc and pip-tazo, this combination, versus no pip-tazo. You could see how they defined AKIs being largely with creatinine or urine output. You will note that there was no increase in dialysis rate with the vanc and pip-tazo in this chart. So kind of moving on to laboratory studies that show that vanc and Zosyn in combination is not as nephrotoxic as vancomycin. So kind of in my studies, finding different molecular markers or novel biomarkers for assessing kidney function. One I came across was kidney injury molecule 1, or KIM1. And in this study of rats, I believe, you can see that the vanc group has higher elevation in KIM1 in comparison to the Vancomycin group. And here's a little bit of a more cluttered slide, but kind of illustrating that same fact that Vancomycin, while having maybe increased creatinine, would have decreased KIM1. And kind of looking at the image on the right, this histopathology score, vancomycin treated alone having kind of greater histopathology than the Vancomycin group, maybe suggesting that there's some nephroprotectivity when you add Zosyn to vancomycin. Here is a slide showing that, the top part shows that there is an increase in, so that's measuring AKI. The middle part is measuring, I believe, need for hemodialysis, and the last part is measuring mortality. And so while there is an increased rate of AKI in patients that are, this is comparing vancomycin and meropenem versus vancomycin and Zosyn. So there is an increased rate of AKI in the Vancomycin group, but there is not increased need for dialysis or mortality. So I came across a lot about cystatin C as a novel and maybe better biomarker for assessing kidney function and damage than creatinine. And just kind of a little refresher here about creatinine and cystatin C. I found this to be a good picture kind of illustrating what I wanted to understand. But I had mentioned that creatinine is secreted, and maybe up to 10 to 20%, maybe even more is secreted, and that could kind of affect measurements, whereas cystatin C doesn't have that secretion. However, different conditions can affect cystatin C, like diabetes, steroid use, and inflammation. So, I'm not quite sure about its utility as far as replacing creatinine in the future, but I will say that it's, just from my limited research, it seems to be a kind of quicker biomarker for assessing AKI, and maybe a better, more efficient one. It seemed that creatinine, as far as a test, might cost around 2 cents to get the creatinine, whereas cystatin C might cost around $2 to $3 to get. So, as far as like running a hospital, that 100 times increase could potentially play a role in using cystatin C in the inpatient setting. So if you would just kind of, this is a study that is a prospective cohort study that looked at patients that were enrolled in the molecular epidemiology sepsis in the ICU project. And here we have patients that were either treated with vancomycin and cefepime or vancomycin and Zosyn, and you can see that cystatin C was pretty similar in both of those, and also this BUN, no increase as far as the Zosyn group. Another kind of image here just showing that in the Vancomycin group, the AKI requiring dialysis at 14 days being decreased compared to the vancomycin group, and mortality being not increased as well. So kind of just summarizing these findings. So pip/tazo was associated with higher levels of creatinine, and thus higher levels of AKI is defined by elevated creatinine. But it was also associated with a trend towards lower levels of cystatin C, lower rates of dialysis, and no mortality differences in the groups. And BUN to creatinine ratio was lower in the patients receiving pip/tazo. So, kind of just reiterating this mechanism for vancomycin and Zosyn and increased serum creatinine. So we know that vancomycin is going to suppress this mechanism, and that piperacillin will competitively inhibit the OAT transporters that we already went over. and these kind of findings that showed increases in creatinine that weren't matched by increases in cystatin C or BUN are consistent with this mechanism, and kind of also consistent with the animal models that we went over that showed that Zosyn doesn't enhance Vanc nephrotoxicity, and it might be nephroprotective instead. I know that somebody gave, I believe a pharmacy resident gave a great talk on the ACORN trial, so I'll just kind of show this graphic that I really enjoyed these JAMA graphics, but showing the effect of AKI or neurological dysfunction in hospitalized patients that were either treated with cefepime or pip/tazo, and not really kind of my topic being the combination of Vanc and Zosyn, but I think that it's important here. Events of major kidney events at day 14 did not differ between the groups, and patients in the cefepime group experienced fewer days alive and free of delirium and coma within 14 days. And then the highest stage of AKI or death was not significantly different between the cefepime group and the pip/tazo group. A little bit more kind of diving into this, that duration of therapy also seems to play a role in this nephrotoxicity combination. So this paper that looked at the incidence of AKI among critically ill patients with brief empiric use of anti-pseudomonal beta-lactams with Vanc, and their conclusion being that it was not associated with a greater risk of 60-day adverse renal outcomes as compared to other broad-spectrum combinations. So just, going over the conclusions that I think that we can come to, that vancomycin is nephrotoxic, and whether we've completely understood the mechanism for that, I think that we can safely say that it's nephrotoxic in a dose-dependent manner, and if we properly dose it in an inpatient setting, we should really see very limited nephrotoxicity. Zosyn does appear to be a pseudonephrotoxin, so kind of that way of increasing serum creatinine without damaging the kidneys. Vanc Zosyn from animal studies appears not to be more nephrotoxic than Vanc alone, and Zosyn could be nephroprotective. I think that we have to think about the ways we assess and measure kidney function and injury, and whether serum creatinine is that best way to do that. And so I would implore us as residents to not reflexively dismiss Vanc Zosyn as an option for treating infection in patients that have acute kidney injury or chronic kidney disease, but also to be, ambassadors for antibiotic stewardship, and to kind of think over our decisions, very deeply about which antibiotic to start, and thinking about just how those decisions might affect future generations of patients and doctors. Here's just a little graphic at the bottom that I thought kind of summarized things in a good way. But I will also talk just a little bit about implicit bias and its role in vancomycin-related AKI. So, implicit bias just being our subconscious or personal attitudes towards specific groups of people that we are just generally usually not aware of. So found this interesting study that found, it was a retrospective study that in patients who were on Vanc, and it kind of looked at their demographics and found that the incidence of vancomycin-related AKI was higher in patients that identified as Black versus kind of independent of other, and it was independent of other risk factors. So thinking, that this study kind of showed that Vanc trough levels, which we don't really use anymore, so maybe under the curve calculations need to be very closely monitored in our patients that are Black. And here are my references, and
all right. Are there any questions or comments? There's got to be some comments in the back of the room. Nobody? No questions, no comments. Everybody wants to go. Everybody wants to vote. All right, so we'll vote. Combination therapy with vancomycin and piperacillin tazobactam has increased nephrotoxicity and should be avoided. How many people think this is true? How many think it's plausible? How many think it's a myth? Looks pretty unanimous. So the next time I'm around in the ICU, this isn't going to come up, right? I'm going to ask, why didn't you put them on Zosyn and Vanc? And they're going to say, well, because their creatinine was 2.1, right?
Never again.
I'm never going to hear that again?
Never.
Thank you. Thank you. Thank you. All right.
I'm just going to add Zosyn.
Sounds to me like, pardon?
I'm just going to add Zosyn to Vanco for the nephroprotective.
There you go.
MRC.
It's actually maybe even nephroprotective. You haven't heard that before, have you? All right. All right, we're busted.